Patient 3, 55-year-old white male, weighs 295 pounds, never had controlled diabetes according to him. Refuses to do multiple daily injections of insulin. Can't really afford Lantus. He was recently prescribed 70/30 insulin, and this guy's a little simpler, so we just said 30 in the morning, 30 in the evening, okay? So usually you weight your mornings a little bit heavier. Takes 4 milligrams of Avandia in the morning. Can't take metformin due to his kidneys. Goes to bed really late, like definitely after midnight, and wakes up for breakfast around 10 a.m. So, he looks like this. So what is going on here? Now that you're getting familiar with how to read and interpret these, you have a very clear pattern. It's not an anomaly. Look at any given one day, just follows that same pattern. He's off the charts on the second half of the day. Any speculations as to how to address his situation? Okay, so some about increasing the morning 70/30. Why do you think there's such a dichotomy here between the front half and the back half of this? He's not taking it. Patients lie. That's the cardinal point to this, is even though he put his little teepee thing here, he wasn't taking it. So I had to ask him about that, and he finally confessed and said that, no, I don't want to take the second one. I'll do the first one, but I won't do the second one. Like, come on. So in the case before this, patients do tell the truth too. That, I swear my morning sugars really are good. But on the other hand, sometimes they just tell you what you want to hear. And that's where the CGMs are a really beneficial tool, is they can tell you whatever they want, but you can see exactly what their sugars are doing and imply what's going on. If 30 units of 70/30 took him down to in therapeutic range, or near therapeutic on this day, but other days it actually hit right in goal where I wanted him to, you imagine if he really gave the second dose, he would in fact be in range. Something else that's a red flag, he only had one finger stick. This turns red if there's less than 3 finger sticks to corroborate the data. And so that's one other thing, you don't see those little diamonds, there's only one. He only checked it once, even though he's supposed to be following several times a day. So it's another clue. Patient 4, this is the last case that I'll mention. She's actually 11 at the time as she came in, but established for fatigue, found to be a type 1 diabetic after she had that classic wasting pattern, very thin, lots of abdominal pain. Started her on 70/30 just to get used to it, but now she's on Lantus at 12 units, lower doses for type 1s, 1:20 carb ratio. Again, with kids, you want to start at more conservative ratios. Type 2 adults, frequently 1:15 ratio, but kids, you always want to start 1:20, even 1:30 when you're starting off, or if they're very little, and using a Novolog pen. So we just started a more defined correction factor for what to do if her sugars were up, but the family's pretty bright, and they were sort of adding a unit or two here and there if her sugars were above 150. So they're sort of winging it a little, and that's okay. Not too bad. I mean, that's the first thing you notice is, for the most part, we are in between the 70 and 140 lines, okay? So the vast majority of it's in this area, which is pretty controlled. We started off, she was crying because it hurt, kind of, when I put the thing on. So then she felt like she was low and she ate all my Skittles. So she started way up here and then overcorrected and crashed. So that was an unfortunate start to this process. Now, keep in mind, with a young kid, this is actually pretty bad, all right? You do not want a kid going to bed and cratering out the entire evening with a low sugar, all right? So that's something you absolutely want to avoid in kids. Now, then she rebounds, and we go on. We got 2 days worth here. So this is our first day, and you notice along with where we're checking here, again with the meals, the insulin, and everything else. And what is the problem on this page? After school, 3 p.m., snack. This was my fault. In the process of educating her, and this always reinforces the team approach, I did not ever tell her or her family that you have to cover all food as a type 1, okay? I didn't tell her to cover this snack after school. She's covering religiously her breakfast, lunch, dinner. This is her Lantus. But here in the morning, when she eats a little snack, small blip, this is what I call the Rice Krispie phenomenon. that she eats a Rice Krispie treat and shoots way over, almost up to 300. But that was the only time that she was high in that process. And again, that was something that we identified through the CGM that otherwise we may not have otherwise known. So that was entirely my fault for completely overlooking that fact that as a type 2, you cover everything except for when you're treating a low hypoglycemic episode. Very comparable on the next day that you can see the exact same pattern with little blips for that morning snack and their afternoon after school snack. And on this pie graph, a lot of green, you know. This is really solid in general. She's doing a good job. This amount of red is you know, forgivable by any means in a postprandial state. The problem is looking at 18% low, granted the most of that came from that one episode where she was low all night, but for a kid, you really don't want any more than 3% to be hypoglycemic in that blue range. You have to conserve kids more carefully and run them even a little bit higher until they hit their teenage years than you do for adults. So like I said, it's a whole separate PowerPoint here, and I didn't want to dwell on that for too long, but I wanted that to address some of the evolving technologies that are in diabetes, especially when you're dealing with injectables and things. Any questions over that particular? They're covered by all insurance and Medicare. Yeah, absolutely. The only requirements are they have to be on insulin. It can be just Lantus, but you cannot get it covered if they're on exclusively orals. So as long as they're on one form of insulin, which typically would be something like Lantus, you're covered. It's not an issue. They've been changing the guidelines as to how frequently you can test. Most private insurance plans, you can test up to 6 times a year. I don't do anything anywhere near that frequent. I'm looking at maybe once a year, twice a year. I think that'd be a little excessive by any standards. But it's also, again, the business model, one of the more reimbursable rates. The machine itself costs about $2,000. Each device costs about $35 that you attach that's disposable, but it reimburses on the order of about $200 per one that you do. So, you know, you recoup the cost of the equipment. Plus, it clearly has a role in how you address your patients and identify problems. Mm-hmm. I don't know about Medicaid, I believe, but I can't conclude that. I don't have a very high Medicaid population in my particular practice. I don't know that I've run it on any of Medicaid patients yet.
I mean, I don't know about other residencies, but ours is like 100%.
Sure. That's true. Yeah, very true. Yeah. Yeah, the comment from the back is that they're simply state dependent. So, but that's something to kind of think about, because the other reason I bring that up is that ties into insulin pumps. New technology is starting to integrate these devices into the insulin pumps themselves. That there's no way we have enough time to discuss all the pumps just at the convention, but they're starting to integrate that technology since the infusion site is very similar. They can detect that, and you don't necessarily get the real-time graphs, but you can have lockouts. So if your sugar starts to get below 50, your pump essentially turns off. So you don't continuously crater your sugar. So you can see where this technology is coming out. I also envision that they're going to start using this in situations like the ICU. Patient comes in with DKA where they're having to check their sugars every hour. That's a pain, you know. So you use a device like this, you can actually watch it in real time from a nursing station. So you can see where all this is going to go, and it has real practical implementation to it.